Okay, the webcast is now live.
Right.
We're ready to go.
Just checking who else was here. Yep. Yeah. One or two still joining, but we'll wait until my clock on my machine says 10. Yeah. Good morning and welcome to today's meeting of the Leicestershire, Leicester and Rutland Health Overview and Scrutiny Committee, which is being held online due to the current COVID situation. Today being 23rd of September, so hopefully those that want to be here on the 23rd of September, you're here. This meeting is being broadcast live to the public on the YouTube channel, and for those not able to watch the footage live, the webcast will be available for viewing after the meeting. Can I please ask that all officers and members mute their microphones until they wish or are invited to speak. When you're speaking, please make sure your video is turned on, we can see what you're doing, and obviously your audio as well. And ideally, if we can indicate that you want to speak with the hand, which is on the taskbar, I think they call it, there's a raise your hand button, and I'll try and keep track of you all. If not, you'll have to wave. So just to go around and do basically a roll call now so that those online know who's here and ask members to introduce themselves. We've had apologies today from Jonathan Morgan and Luis Fonseca. So I'll start, it's alphabetical, of course, in surname. So I'm Kevin Feltham, the chairman today. Councillor Aldred. Nope. Councillor Chamund. Nope. Councillor Mrs. Hack, I can see you.
Yes, I'm here.
Councillor Harvey, I know you were there. Yes, Councillor Harvey.
I'm here.
Yep. Councillor Dr. Hill, you're there.
Yes, thank you, sir.
Turn over the page. Councillor Kitterick.
Present.
Thank you, Patrick. Councillor March.
Councillor March is, put it on the chat bar. She's struggling to join the meeting due to IT issues. Someone can get in touch with her.
Thanks, Patrick. Councillor Orson. I've seen him somewhere. Yes, he's there. Councillor Orson, I can see you. You're muted. Definitely can see you, Councillor Orson. You're not answering. Oh, well, I can see him. Councillor Page, I've seen you. Yep.
I'm here, but I have got Councillor Hack on my screen, her agenda. So all I've got, it is a big agenda, the meeting agenda.
I think Mrs. Hack has shared her screen by mistake.
Thank you. Thank
Sorry,
you.
did it by accident.
No, that's all right. Thank you. And morning, everybody.
Morning. Councillor Parton.
Good morning, ladies and gentlemen. I'm present.
Thank you very much. Councillor Sangster.
Hi, good morning.
Thank you very much. Councillor Waller. Seen you.
Good morning, everybody.
Yes, I've seen you. There you are. Councillor Westley. Paul? Nah. Not seen Paul. No. And then we've also, from Health Watch, we've got Mukesh Barrow. Not yet. And I've seen Janet Underwood. So Janet Underwood, thank you. So that's the roll call, so to speak. First item is Chairman and Vice Chairman. And for this particular committee, the first item is just to note that for the 2021 year, as per the working arrangements and terms of reference of the committee, I, Dr. Kevin Feltham, have been nominated by Leicestershire County Council as chairman, and the vice chairman is Councillor Patrick Kitterick, who's been nominated by Leicester City Council. So it's just to note that. Nothing you can do about it, I'm afraid. So then the minutes of the previous meeting, which we held on the 3rd of July, I propose that these minutes are taken as read, confirmed and signed. Agreed? Question. Yep, there's a few people nodding. Thank you very much. We received two questions from a member of the public, Sally Roy. I think you work at De Montfort University, don't you? answers have been circulated to committee members and published on the County Council's website. I understand, Sally, that you have a supplementary. Would you like to ask it, please?
Oh, yes. The CCGs are launching a public consultation on the hospital reconfiguration in a context in which it's becoming clear that COVID cases are rising quite quickly and that we may be going into a second wave. This is likely to compromise the usual activities which we associate with formal public consultation. Would now be a good time to take up the offer of advice from a fellow of the Consultation Institute to inform the JOSC's scrutiny of the adequacy of the consultation process?
Thank you very much. I thought you were going to ask a question supplementary on question 1. That was definitely question 2. However, we'll take it.
Sorry, Chair. I thought my first question was about the scrutiny of the PCBC and the consultation. That's why I linked it to that one.
Yeah. Okay. But, yeah. It's. I could argue that it's not strictly the question, but anyway. We'll take some advice on it. I mean, I can't answer you directly because obviously I'm not running a consultation, but we have obviously we have 2 meetings scheduled. Next big one is the 15th of October when we'll firstly go into it, but we also have one on the 9th of December. And in fact, I'll announce it now because I think it's worth saying to people, other people that might be watching. In fact, members of the Joint Health Overview Scrutiny Committee also did have a private briefing about the way the consultation was being run. We had that on the 20th of August, and we went through for several hours the format, the style, the availability of it for equality, diversity, all sorts of things. We have had that, and that's been fed into what we'll be looking at in next month. But I'll take advice, and if there's anything other than that, we'll let you know. Thanks, Sally. Right, and the next item. Gosh, good job I have a bit of paper, you know. Couldn't cope otherwise. Item 4 is questions asked by members under Standing Orders 7.3 and 7.5. We haven't received any questions from the members. Urgent items. I've got no urgent items on the agenda. Declaration of interest. Members, does anyone have any interest to declare? Nobody. Thank you very much. Presentation of petitions. We have no petitions today. And we move on, therefore, to item 8, which is in the big agenda pack, is on pages 17 to 54. And this is COVID-19 update from the NHS. Excuse me, my COVID. To present this item, we should have Caroline Trevithick.
Yes, morning, Chair.
Sorry, and Sarah. I've seen Sarah Prima. I've seen a picture of you. Yes, from the LLR CCGs, and I gather that Sam Leake and Eleanor Muldrum from the UHL might also be on the call. So I'll leave it up to you, Caroline.
Thank you, Chair. Apologies first from Andy Williams, who's on annual leave. He would have been here to present this item, but you've got me and, as Chair said, a number of representatives from both the CCGs and the Trust. So I've got Sarah Prima from the CCG, Tamsin Hooton from the CCG, Tom Leake and Ellen Melbourne from UHL. I'm going to do an overview of the paper because I think it's going to be easier for us to do that rather than sort of chopping and changing. But my colleagues are here to support any questions as we delve into the issues that I know councillors will want to talk through. But Sam's going to, after I've finished presenting the paper, Sam's going to just pick up the cancer presentation that we've got at Appendix 1, because I think the detail of that, it's important to go through that. So I'll start off with cancer, and I suppose I'm just going to give some headlines with this because Sam will go into more detail. Kind of doing a bit of an update going back a few months to the start of the pandemic. The NHS needed to balance safety and risk for patients with cancer, and to ensure that we didn't outweigh somebody's risk of catching COVID with the need to manage their cancer. So we've obviously been through a process where we've been undertaking reviews of individuals to ensure that those that need to be seen or can be seen virtually have been seen, or those that can wait can wait. We've put some mitigation in with virtual consultation, so we're not bringing people into a central place, and we've also put in some harm reviews to check, particularly those for the long waits, the 62-day waits, that we've got some mechanisms in place for monitoring those patients. And we've got a cancer group that works across health and social care that's been coordinating this. In terms of recovery, and Sam will go into this in detail, we've been building on different ways of working. COVID has brought with us a different approach that we can work virtually where it's appropriate and work differently across health and social care. But we've got a faster recovery for our cancer performance than other areas, and that has really put us in a good place. And referral numbers are back to pre-pandemic numbers, and we're continuing to catch that. I will caveat everything I'm saying with the risk of a second peak. And of course, as you would expect, we are planning for that as well as planning for recovery. And it does make it different. And I think Sally's question earlier around how we're going to manage with this, we've always got that at the back of our minds to think about. So the second area relates to PPE, or personal protective equipment. From the start of the pandemic, that became a real concern with us, that we made sure that we'd got the right level of PPE for staff working in all areas, not just in health, but in social care as well. We needed to ensure that people who were looking after patients in their own home and had the right PPE to support the care that they were given. And we have worked across the system to provide a system response, and that's been local authorities, CCGs, trusts, coordinated through the Local Resilience Forum group that assisted us in moving PPE around the patch to make sure it gets to the right place at the right time. We've now moved into a much more stable approach with PPE and a central repository for PPE, and the portal is working with a 48 to 72 hour turnaround to do that. In addition to the standard PPE, we've made sure that any procedures that include what are called aerosol generating procedures, so these are procedures that might happen in patients' own homes, where staff are at increased risk of exposure to any kind of aerosolized particles, that we've worked with them to train them in using the additional PPE, but also have access to that PPE. That type of PPE is usually associated with hospital care, but we have a number of patients in the community that needed that. So the next section relates to winter. From a winter perspective, we've always had a winter planning process, and the process has been compounded but also enhanced by COVID. It's brought with us additional challenges, but it's also brought with us a drive to work much closer together as a health and social care community in delivering what's needed for our population, not just focusing on a hospital perspective or a community perspective, but working together to ensure that patients get the right care where they need it. For this winter, we're expecting an increase in emergency admissions and attendances, and we've got a health and social care group that we've had running for a number of months now, that is rich in data, so it's really well informed by local information associated with activity in hospitals, but also the COVID activity as well, so that we can respond to the needs. The paper talks about risks that we think are associated with winter this year, and they're not unusual. They're not really different from last year, but they're, as I say, they're compounded by COVID. So it's the increases in ED attendance, ambulance handover delays, the need for emergency beds and staffing. So the COVID aspect presents risks for us because we're having to implement increased infection prevention and control procedures and ensure that we're keeping suspected and positive confirmed COVID cases away from people who aren't suspected or are negative. But also it's compounded with our staff, because it's not just a patient population we're trying to manage here with COVID, it's our staff population and managing sickness and absences while people are away from work for testing. We've a lot of picking up on that workforce aspect. We've a very good piece of work happening around workforce to support people being able to get tested appropriately quickly and get them back into work where they are negative. But we've also put some actions in place, including increased telephone and face-to-face appointments, including what we've classed as hot clinics, so clinics for those suspected and confirmed cases of COVID, so that we can completely separate. We've put support in for care homes. Again, it's a health and social care response for care homes. We want to keep people in care homes if that's the most appropriate place for them. And so support from the ambulance service, but also consultant from UHL to make sure that the staff in the care homes, or the GP is providing input into the care homes, has the wraparound support that it needs to keep patients safe. And the same goes for patients in their own homes, so enhancing that home first approach and keeping people safe and in their own home, but making sure they've got the right input and support for that. We've also increased, we've got a plan to increase beds in UHL and LPT, with some surge beds in LPT should they be required. And then running alongside all of this is the flu vaccination programme. You will have heard all over the media that we are absolutely in the process of vaccinating over 65s. The extended flu programme this year talks to including over 50-year-olds as well, and extending the school age programme, and our flu plan that is just about to be signed off by Public Health is absolutely focused on that. And in addition to that, we're planning for a COVID vaccine if and when that arrives, to ensure that we've got the right mechanisms in place to support at-risk people, frontline staff who should require COVID vaccinations. The next section of the report talks about student nurse capacity that we've had in UHL particularly, and Councillor Hack, I'm going to skim over this because I think Ellen has done a really good, or the Trust has done a really good response to it, but I think in essence it does talk about the fact that we have had students working in the Trust. It's been wrapped around by a national framework that UHL have worked really closely with the national teams, but most importantly the university and the students themselves, to ensure that they've got an appropriate approach to bringing students into the wider workforce, and they've been fantastic. You know, they've absolutely done what we've needed them to do and worked really, really hard to support us in our COVID response. The next steps for that, again, it's a national piece of work that we're engaged with to make sure that we are able to support the students as appropriate. From a mental health perspective, we've been really focused on the health and well-being of our staff. Our COVID response would have fallen over if we hadn't got an appropriate health and well-being response for staff, and particularly focusing on Black and minority ethnic and shielded staff. Because of course, again, our staff fit into the same risk population that the rest of the population does. And we've pulled together a workforce group that is really looking at the health and well-being of our workforce to ensure that, apologies, I just need to open the door. I hadn't realised that was going to happen. So just to make sure that we've got systems in place, not just to make sure that we've got workforce available to deliver the care across health and social care, but also that we are supporting our staff from a mental health well-being as well as a physical health well-being perspective. and we can touch on that more in questions. I see some hands have gone up with that one. And the final stage of the report refers to the phase 3 recovery. We've included the letter from NHS England that really describes the expectation of the NHS around phase 3 recovery. And we have plans in place. They were submitted to NHS England on Monday, our second version of those plans, with the intention that they want us to return to near normal levels of the kind of the pre-COVID particular. The phase 3 recovery plan absolutely links to the winter plan, the cancer plan, making sure that we've got plans in place to pick up patients who are long waiters, who've been waiting 52 weeks and more for procedures, and that we've got plans in place to bring those patients into healthcare and get them treated. The caveat again is that we will absolutely put all our effort into that until something else, until potentially a second wave comes, and we have to then readdress what we're doing. But we're not taking our foot off the gas to be able to continue to do that. But there's particular focus in that letter around cancer and meeting the unmet need. It's been a particular concern of ours that whilst we went into lockdown, people were at home and not presenting to the NHS with concerns, and therefore we've got a lot of unmet cancer need particularly. We also need to consider the restoration from a primary care perspective. So our GPs have had to put in place different mechanisms in the same way as the trusts have to manage positive and negative patients. But also, let's not forget our mental health. And so mental health and LD and autism has been a particular focus because they tend to be some of our hardest hit areas is mental health, as well as some of the physical health. So I hope I've given a flavour for each of the bits in the report. You have read the report, so you've got the information. I'm just going to hand over to Sam then, if I can, just to cover the cancer aspects, because I think that's particularly important. And then if it's OK, Chair, we'll stop for questions then.
Thanks very much.
Thank you, Caroline. Thank you, Chair. So just briefly to add to the points that Caroline has raised, pre-COVID on our cancer list, we had approximately 3,000 patients, and that's a normal number for us. During cancer, during COVID, that number dropped by 50%, but we are now back at 3,000 patients on that list, and they're GP referrals or patients that have entered UHL on a different pathway, and then there's been a suspicion of cancer, and they've gone onto a cancer pathway. During the pandemic, we've ensured that we followed national guidance and also society guidance for each of the individual tumour sites. So there have been changes to pathways that have ensured that patients can access us as quickly as possible, and also society guidance to ensure that we manage patients that can't access us by coming into the hospital. We've also ensured clinical contact either through a consultant or by a clinical nurse specialist for any patient that was unable to come in or refused to come into hospital during COVID because they were worried about coming to a hospital site. We have a harm review process for cancer anyway for any patient that's waiting over 62 days, but we've extended that harm review process for any patient that might be delayed due to COVID, either because we've had a delay because we haven't been able to provide their treatment in a timely way, or because the patient's delayed their pathway again because they've chosen not to come into hospital. And as Caroline has pointed out, we've seen a really speedy recovery in terms of our performance in cancer. And I think that's because we've been prioritising cancer above everything else within UHL for treatments. And we've put a lot more time and process management around these patients because it was the right thing to do. Our referrals are back at pre-COVID levels. We are seeing an increase in conversion rate now for cancer. So we are seeing patients that are coming in, more of those patients do have cancer. And I think that's because of the delay that we saw during the COVID period. We're about to start a pathway, which is called non-specific symptom pathway, which means that GPs will be able to refer quicker into hospital for a consultant's opinion on a patient that they think may well have cancer, but they're not sure which tumour site that patient falls into. And there's really good evidence to support that helps identify cancer quicker for patients. So we think that will help enormously. From our 62-day performance, we are back at pre-COVID levels, so patients waiting over 62 days, and those numbers continue to decrease, so we're doing really well there. The largest numbers waiting over 62 days are urology patients, and predominantly patients waiting for prostate cancer, and they're our lowest risk groups. So they fall into category 4, so the lowest risk group for surgery. Nationally, for a 62-day performance, we are 105th out of 139 trusts. And again, our position is improving. Patients waiting over 104 days has continued to fall. And as of the beginning of this week, there are 16 patients waiting over 104 days. That's the best we've been in about 2 years. Some of those are complex patients, and again, some have chosen to delay their pathways because they've not wanted to come in because of COVID. Overall, we are seeing an improved performance position, so that is positive. We obviously have more to do, and that is about our theatre capacity and the decreased capacity we have because of downtime between cases, which we've had to do because of COVID. We've seen some really great transformation during COVID, some things that have been done on pathways that have helped patients, and we're currently reviewing that to see whether we will continue to do those now pre the second wave of COVID. And we're just starting our transformation programme, which was paused during the COVID outbreak. My thanks particularly to the cancer team who have worked really hard on this. Thank you very much.
Thank you very much, Sam and Caroline. Thank you. I've got 4 hands up. First one, Amanda Hack.
Hi, thank you. Just first of all, thanks ever so much for putting such a comprehensive response in about the 2017 cohort. That was really helpful. And I just had 2 specific questions, if I may. Also encouraged to see the work being done on the mental health of the colleagues that work within NHS services. How do you feel, how resilient is the staff team in light of a second wave, particularly understanding that there has been this sort of don't stop services that has been sort of brought forward, that we need to continue delivering services as much as possible on other elements. How resilient is the staff team, and and what support are you putting in place to ensure that colleagues can cope with the second wave and how busy they're going to be inevitably? The second question around mental health is about mental health of the population that you're seeing, and whether or not in ordinary services are you having to provide more mental health support alongside other services such as cancer treatment and other things. The second question was specifically on the cancer weights, and I've seen that obviously the catch up has been there. And certainly we look like we're back to average, but there's clearly a set of individuals that are not coming forward because we're not on the annual average. What are we doing to try and ensure that people are coming forward and getting that initial consultation that they need? 1, to maybe put their mind at rest, but 2, to get them on the appropriate pathway as quickly as possible. Thank you.
Thank you, Councillor Hack. I'm going to bring in some of my colleagues here, so just to give them the heads up. Eleanor, given that our biggest workforce is in UHL, if you wouldn't mind be able to pick up on that. But we've got David Williams from LPT. David might be able to give an LPT perspective as well, but also David from the mental health services perspective, if you could do that. I believe Angela Hillary is with us, but she's got IT problems. And then Sam, if you could pick up the cancer one, if that's okay.
Okay.
Do you want me to start? It's Eleanor Meldrum here, Deputy Chief Nurse at UHL.
Please, Eleanor.
Okay. Thank you. I think you're absolutely right. We can't underestimate, I think, that the pressure that the staff are under. At the present time, we are undertaking winter preparedness. So there is that sort of business as usual that we have to keep sort of an eye on, really. But we have absolutely ramped up a lot of our support mechanisms for staff. So that includes facilities within our occupational health department, but also I think it is that general, visibility of the senior team with staff. It is the business as usual around recognition of staff. So we still have, the awards, the recognition work that goes on in UHL in particular to recognise how hard staff are working. And actually, they have all in the last couple of weeks. We've sent out a letter from the chief exec and the chairman, thanking them for their contribution in readiness, I think, for what we're about to probably face. I think it also is around making sure, in terms of business as usual, that we carry on things like our professional development of staff, and that is clinical and non-clinical. I think that is good for staff well-being in terms of still seeing that they have a career pathway, that they have that sort of opportunity, I think, to develop and stay within LLR. We are really fortunate in UHL at the moment that I'm going to focus on our nursing vacancies and our healthcare support worker staff. The vacancies have been maintained over the last few months and actually have slightly improved, with some of our international nurses finally getting on the register, but also our student nurses qualifying and coming on board as registered nurses. And to be fair, we are seeing the lowest vacancies that we've seen in the last 2 or 3 years. And so that has come absolutely at the right time. So I think our focus, certainly from a chief nurse perspective, from the nursing workforce, is about carrying on the business as usual in terms of valuing and recognising our staff, giving them that support. And I think recognising there are going to be hotspot areas. So our ITU staff, critical care staff, and our front door staff. In terms of the ED department, we are providing very bespoke support mechanisms for them. It is going to be difficult. I don't think we can underestimate that. And we've certainly seen higher than average sickness absence levels. That is short term predominantly because it's about the shielding or the self-isolating, particularly with track and trace in the last few weeks. But we are very nimble and fleet of foot in terms of mitigation to cover vacancies or staff shortfalls. But it is recognising, I think, that our staff need more this winter, and we're ready for that as best as we can be. Does that answer your question?
Thanks for that. Yeah.
Yes, thank you.
Thanks very much.
Thank you.
So I think we've got David now, just to pick up the wider mental health perspective and LPT. Yeah.
Yeah, thanks.
Thank you, Caroline, and good morning. Thank you. My name is David Williams. I'm Director of Strategy and Business Development for Leicestershire Partnership Trust. So in terms of lots of staff support, we've just talked through, Leicestershire Partnership Trust continues to develop and support people as well to pick that up. And I think there are an awful lot of additional resources and support that the NHS has been able to provide to its staff to work things through. But I'm also very aware that as we go into winter, this is an additional pressured time for our staff, and we are investing and spending more time with time out and additional opportunities to support people. I guess that also reflects about how people are feeling generally in the population, and the demand for wellbeing and mental health support is seeing an increase and is seeing work that we're doing and working things through. In terms of supporting that, I think the whole system across Leicestershire, Leicester City and Rutland is coming together and really championing the importance of wellbeing and mental health. The single access point that we launched during COVID provides a 24/7, 365 day a year opportunity for any member of the public to contact us for advice, guidance and signposting. I think also the opportunity, and the government are very aware, and we're picking up with in LLR, is the opportunity to make sure that the mental health investment standard, which sets a commitment for the way that the NHS is really going to champion mental health and wellbeing, is very much honoured and taken forward. So there are lots of different bits of work there about supporting just the general public, but also our staff in making sure that we support everybody around positive mental health and wellbeing, as well as mental health supports. And the final bit that I just wanted to add is we're really interested in already exploring with voluntary community sector as well as local authorities about how we all come together to support wellbeing, because this isn't just an NHS issue, this is a society need, and actually supporting wellbeing by access to being able to not be lonely, by being able to get exercise and all these sorts of things are challenges during COVID, but we can come together as a system, work together, we can deliver this in different ways. So that's one of the other pieces of work that we're doing. Thank you.
And finally, Chair, we've got Sam just on Councillor Hack's question around cancer.
Thank you. I think there's two strands to that. I think there's the sort of the patient sitting at home not yet going to their GPs, and I think there's sort of the national communication around that in terms of encouraging patients to go in, and the concerns around cancer. And then there's patients sitting on pathways that are worried about coming into hospital for treatment. And there's communications from the East Midlands Cancer Alliance, there's communications from LLR, excuse me, comms team. There's been a lot of work with primary care and GPs in terms of reassuring patients to come into hospital. We're doing a lot of work with patients and doing patient stories and using sort of social media around that. And also our CNS team have been absolutely fantastic at communicating with patients that are worried about coming into hospital. We've learnt a lot through the first wave, and we're working now on our comms strategy for the second wave to make sure that the patients don't feel unsafe about coming into hospital, contacting their GP the second time round. Thank you.
Yeah, no, I think that's a big issue. I know of a number of people that are very well early on in the pandemic. One of them, in fact, my neighbour, had a slight fall and got taken into hospital, and was terrified basically about catching. Yeah, actually more from the ambulance, I think she said, which I thought was interesting. That was early, I'm sure. You know, sanitisation, all the other things have been solved, but it does show, I think, where people's concerns come from, don't they? Next question, Ted Parton.
Thank you very much, Chair. What I'm going to say now is going to look like a criticism. So apologies for that, because I'd like to thank you very much for all your work. The first question I've got is regarding it's the UHL cancer update. Now, not having any oncology training, I did find this report, this presentation, Appendix 1, difficult to negotiate. The specifics were the actual presentation. The graphs and metrics were difficult to understand because of the size of them. So it's a technical question. What can be done by your communications team to alter the way that these are presented, because I do struggle to read them, and some of the graphics aren't actually even complete because they seem to have been blocked out by other things that have been inserted on the paper. So because of that, I was really struggling to understand it. So it was helpful that we got the verbal update. That will be the first question, and then I'll tackle my next points.
Okay, thanks, Ted.
Thank you, Councillor Parton. I think what I'd like to do is take that away and ask for us to come back to you with something that presents it in a format that might make it easier to read. So I'll take that one away, and we can pick that up with the comms team, definitely.
That's great. Thank you very much. Because as I say,
Sam, was there anything you were going to say, Sam? Yeah.
Sorry, I was just going to say, firstly, apologies. It is quite technical, and we can either present it in a different way, or I'm really happy to pick up a conversation with you afterwards, because sometimes it's easier to describe it and talk through it. So really happy to do that if that would be helpful.
Thank you very much. Would we be able to ascertain we're focused on cancer. Two other points which I'd like to discuss are what is the similar picture that we're seeing with cardiac patients not presenting, or backlogs for procedures there and presentations into hospital. And then the last question is, what figures do we have, especially with the single access point the gentleman spoke about, for calls into the system for mental health? It's absolutely excellent that we're talking about the mental health of the staff. It's got to come first. The staff have to come first. In terms of the general public, what are the numbers like for the presentations through the single access point, and what are the trends we're seeing there, especially the further this pandemic continues?
So, Councillor Parton, and apologies, I've got some background noise from outside. I'm not sure we're going to be able to respond to that in the time we've got today. So if I can take that away and we can get that information to you for cardiac patients and for mental health.
That's completely understood.
Thank you,
Caroline.
And actually, the other thing is to say that David Williams, who was on a minute ago, and the LPT team have had to whiz off. They might have been able to answer some of it, particularly about mental health, but they've gone. So I think if Caroline could pick that up and let us know, that'd be very good. Thanks, Ted. Melissa, I thank you very much for joining us. So if you want to ask a question, although I gather the question did involve a bit about the mental health as well.
Not this one, Chair.
Oh,
thank you. Can I just clarify? Have all of LPT left at 40 minutes into a meeting? There's nobody here to answer any questions about LTP.
Apologies for that one, Councillor March. Angela Hillary was planning to stay, but she's had IT problems. She could see but not hear, and not be heard either, I think. So I think she's going to try and resolve it. But we will do our best. You know, we are working as a system, so we will try. It was the specifics of Councillor Parton's questions around access times, not be it. I haven't got that information to hand.
Yeah, I guess I think maybe it's worth us just noting that, because I know that the public and certainly the people that we all represent place a high value on us being able to do our jobs properly, and that there's been, for various reasons, nobody's particular fault, but you know, it does seem important with the severity of the issues we're discussing that we're able to do that properly. So thank you. So my question is, I'll just try and ask them all until the chair stops me. Apologies, Kevin. So the report talks about peak COVID, but looking at the news as I do, I fear we're not anywhere near peak COVID yet. Do you share my nervousness about our ability to manage the winter this year? And the context of that is last year winter was really mild, and yet I remember sitting in meetings on this committee where we talked about how it wasn't just winter pressures, they were annual, all year round pressures now that we were facing. So if it's a harsher winter, does that put more pressure on this, and what does that mean? And also, I guess my other concern is about shielding, and there's over 13,000 people in the city who are still shielding and have been shielding since March. Obviously, many of them will be frailer, older people, and I'm concerned, given how less mobile they'll have been, about an increased risk of falls. So my question, and that then those falls would lead to pressure on the A&E door and other parts of the system, and that those falls are increased by a lack, I guess, of them living their normal lives, but also therapeutic interventions and falls prevention stuff. But then those people are then particularly at risk to COVID. So we end up in a bit of a tricky situation. So I've got a question specifically around that. And then my final question, I promise, is for now, is again about those who are shielding. And I support completely the rollout and the kind of the you know, those targets being high in the flu vaccination programme, but 13,000 people in Leicester City, more than that, haven't left their home since March on the advice of the NHS. And how are they going to get flu jabs, and how are we going to ensure their ability to access those flu jabs? Because it strikes me that they are also going to be the people most in need of those flu jabs and most in need of that stuff. Thank you.
Okay, so Tamsin's going to come in and answer the winter, but as the flu lead, I'll answer the flu question on that. So we know that we had to do something different this year for housebound patients, because our numbers of housebound patients because of shielding has increased. So we have been working with primary care to support increased staff to go in to do those housebound patients, and we've got a we're using dentist. I can't remember the term; it's gone out of my head. But we're expanding our numbers of staff and types of staff that can go in and do testing. So we do have a plan to support housebound patients, recognising that number has increased because of COVID. But Tamsin's going to come in and cover the other aspects around our ability to manage winter, and particularly falls. I think that's a really good question, one that we've been concerned about ourselves.
The dentists are going to vaccinate 13,000 people.
So we've got dentists that are allocated to primary care networks. Foundation Year 1 dentists, that's the term I was looking for, so apologies for that. Who are allocated to primary care networks that we can use as a workforce to go in to vaccinate people. So yes, that's the specifics. Okay, so Tamsin, over to you then. Thank you.
Of course.
So apologies, I've got a slight cold, so I hope you can hear me. So in terms of confidence about how we manage winter is always a challenge for health and care services, and as the report sets out, obviously this year with COVID still in the community, that exacerbates some of that. So one of the really key things is that we support people to stay away from emergency services where that is the right thing for them. So to decongest those emergency sites such as ED, and we'll talk about, I think, 111 first a bit later on. I think what we've experienced through the first phase of the pandemic was a real drop in activity and demand for urgent service and people seeking care through non-face-to-face means. And as much as possible, we need to try and preserve that, because that's one of the ways that we'll keep our population safe from risk of infection as well. If our experience is anything like that of Australia, though, and our flu season tends to follow on and mirror Australia's, they've experienced a much less severe flu season because of the social distancing that people are putting in place, and because some of the more vulnerable in our communities are staying away from social contact. So we have to do everything we can around the flu vaccination programme, but I think we can also expect some positive benefits from the fact that actually people are being encouraged to keep distance and therefore less exposure to catching some of those seasonal illnesses. I'm not an advert for that at the moment, am I? Really? But so that has to be a key part of our strategy. So the report lists some of the things that we are doing to manage demand and make sure that as far as possible, we are keeping people safe and well in non-acute settings, particularly the frail, older population, and vulnerable population, which links also to your question about falls, I think. So we have a falls prevention strategy, which we are in the process of reviewing, and I think particularly in some parts of the geography and Leicestershire County Council, thinking more about what the model of falls intervention is. Therapy services have continued to be delivered throughout the COVID period. The way that therapists have worked has been transformed, actually, with a lot of non-face-to-face delivery of exercise programmes, although many of the assessments are still done face-to-face to get a real sense of that individual. Earlier this year, we moved to have 7-day therapy interventions in our community, which we've never had before, and that's been fantastic in terms of being able to respond quickly to somebody who's had a crisis in their mobility and to get them on the road to reablement. And we are now starting a joint recruitment process with LPT to increase the availability of therapists in our community teams as well. It's really important that we have the capacity to be able to work with those people, both responding to crisis, but also people post-COVID who often are quite breathless and struggling to get back to their normal levels of mobility and exercise, and that we don't let those people continue to stay at home really and not maximise their opportunities to move about. So there's a lot of work happening with LPT to make sure that we're bringing therapy services on stream as far as possible.
So just to clarify, Tamsin, thank you for that. I appreciate that response. My question about people who are shielding, are these new 7-day therapy teams specifically contacting people who have shielded and therefore are at risk in advance of them having a fall? Is there some active, because they might not have seen a doctor or any kind, a lot of them might not have seen any healthcare professional for 6 or more months?
No, we're not actively reaching out to shielding people specifically with therapy teams. We have actively reached out to all shielded people jointly with the local authorities in terms of what services they require. If mobility is an issue, they will be then routed through therapy interventions, but we're not having a kind of blanket coverage of contact with shielding people because of through therapists.
Thanks very much. Okay.
Thank you.
I've got 2 more, Patrick Kitterick and then Rosita. But Patrick.
Thank you very much, Chair. On the page, I'll find it. In the CCG COVID report on page 19.18. It refers to the PPE portal can be used by the following services. Each category of service has a weekly order limit. Can you take us through that? And are we going to see the situation? Because when somebody says order limit, it's a little bit concerning. Will there be a point when you say you've exceeded the amount of PPE you've got? Am I reading that correctly? The other one is in terms of the winter flu jab, and I do realise we're going to cover this at the Leicester City scrutiny, but you say your aim is 75% of flu jabs. Now, I've seen that referred to as in you hope the take-up will be 75%. The question I'm going to put straight is, are people going to go, particularly those in the identified groups for a free flu jab, are people going to turn up in the next few weeks and months and be told you can't have a flu jab because we're not able to administer it? Do we think that will happen? And just finally, phase 3 of the report, reading it, is phase 3 as detailed in the agenda, has that just been overtaken by events now, or is there some ambition to still implement it?
Okay, thank you, Councillor Kittredge. So in terms of the order limit for PPE, yeah, it is absolutely as it says that there is an order limit, but those limits are based on usual usage. So there's a science behind it. What we don't want to happen is for organisations to stockpile PPE, so it's taking it away from other areas that really need it. So this worked really well in the first wave to ensure that that there was availability of PPE, but also what we didn't want to do is have stacks of it in one area that's in cupboards when other areas were really not having access to it at all. Those order limits, we do need to work with organisations if they flag anxieties about it. That's what our PPE group is focusing on, taking those concerns into that group and working with them. If their service has changed, their limit needs to go up to accommodate that service change, for example. In terms of the aim for 75% flu coverage. This kind of talks to the fact that we know that we've got variation across primary care, particularly in terms of flu vaccination, where some practices seem to be really, really good at getting their patients vaccinated for flu and others don't. So our comms campaign for flu is to really raise the profile of it this year with people as well as with practices, and we've got support into practices where we've got those low delivery practices from last year's data to support them to think differently based on the way other practices are working to access their population. In terms of availability of vaccine and availability of staff to deliver it, we do believe that there's enough of both. There are some challenges associated with ensuring that we've got the national vaccine flow right into LLR, but those plans are in place to ensure it happens. And for those of you that have tried to get your vaccines, we've started with the over 65s. We'll then move on to those with long-term conditions, and then we will move on to the expanded flu programme. And it's designed that the vaccines become available as we move through those stages of the flu programme. But the comms is really important here, particularly with those hard to reach groups. And we're building on the lessons that we've learned from the Leicester COVID outbreak as to how we supported people coming forward for testing. Can we do the same to get them to come forward for flu vaccination as well?
Can I come back on those?
Yeah, of course.
I had the phase 3 thing, but if I come back, so my concerns about the weekly order limit is it's a category service, so it's GPs, it's pharmacies. So and I don't expect you to produce it here, but I would like some more data on this, because if we find that this, you used the word usual usage, yeah. Now the one thing that we know about COVID is it tends not to be usual, and in a sense, even the pattern of usage may change.
Yes.
So I mean, again, I wouldn't wish to. I don't think it would be the best way to communicate it either for you to give us a verbal response. But if you can have, if we can have some more written, detailed information about that, because as I said, weekly order limit sort of certainly sets off a red flag in relation to ourselves. On the flu jabs, I've never had a flu jab, and I'm not in the group for a free one. But certainly, if I were over 65 and sat in Leicester today and tried to get a flu jab, how long would I be expecting today to wait to get one?
So you would have been contacted by your GP practice. That's the idea. You're called for it. So rather than expecting people to do that, the comms campaign is to augment the call. So that the practices will be calling over 65s in and saying, please come for your flu jab. The comms campaign is aimed to say, don't ignore the request from your practice to come in to have that vaccination.
OK, so and we found this with some of the shielding things. People who thought they were on a shielding list from the doctors didn't. Yes. I know age is a little bit more, definite. Yeah. But if, say, there's somebody over 65, when should they have expected to be contacted by their GP?
So that is happening now. So we're at the start of that process with the over 65s.
So when will that invitation process end then?
I'm not sure about when it ends, Councillor Kittrick. It will continue because we've got a recall process in place as well. So it's call and recall.
Yeah, again, it would be helpful, because if we are particularly concerned about people who fall through the cracks, if you don't know that if you don't get a letter, you may never know that you were supposed to get a letter, if you know what I mean.
Yes, and that's what the comms campaign. That's why we're doing the double-edged approach.
Yeah.
To say, and so people over 65, if they haven't heard, then the comms campaign will be make contact with your general practice.
By when?
Straight away, to contact your general practice this week to get your comms flu vaccination.
When's that going to go out?
So those comms messages have already started.
Yeah, they are.
Sorry, so the message is wait for your GP to invite you, but we don't know when all those invites have been sent out by.
No, the messages for the comms campaign are that over 65 should be getting their flu vaccination. So
they should be contacting their GP.
Yeah, but the GP will have done it in the first place. The comms message is a backup approach to that. If people ignore the text, or if they haven't received it, or they don't really understand it, the comms campaign is the backup approach.
I've got to say, I'm struggling to understand this, and maybe I'm a bit hard to reach. So. We don't know. I presume that GPs are sending their stuff out in a kind of, they're trying to not get a huge rush, so they're kind of layering out that the letters are being sent out. But we're not.
No, they'll go out and. Feltham is nodding that they will send their requests out, and people then book themselves into a flu clinic.
Yeah.
Right. Yeah. Okay.
No, I mean, this year I've been having flu jabs for 12, 13 years, but the last few years from the GP as opposed to the hospital I used to work at. And I had, so the last 2 years I've had a letter. This year I've actually had a text as well to remind me to book in, and I booked in straightforward. I actually did a drive-through for a change. I thought I'd try something different. Drove in, stuck my arm out the window, jabbed, drove off. That's the way that, I mean, obviously I didn't have to have a drive-through. I could have actually booked a proper appointment. But yeah.
Please forgive me for being dense, though. But it's a case of, I'm not being funny, but when we're talking about groups that don't pick up their flu jabs,
yeah,
it's not the people who've had it done every year for 12 or 13 years. Yeah. And again, probably not to labour the point because other people have got questions. If you can come back to us with this, and we are going to cover it at Leicester City, so I definitely won't labour it. Certainly what we'd be looking at the Leicester City thing is a little bit more clearer, because one of the roles we have as councillors is a community advocates. People will come to us from our advice. We can proactively tell people. And I'm not really sure how I would advise somebody if they said to me, I have a typical question we'd be looking for is, I haven't heard anything from a GP. What can I expect? So we'll pick that up later. And just the fact, so if you can come back to us on the PPE weekly order limit and the flu jabs, and the phase 3, is that pretty redundant now then in light of events?
Sarah, do you want to come in on the phase 3 bit?
Good morning, everybody. No, it's not redundant, Councillor Kittrick. What we're trying to do is to keep our phase 3 recovery going at the same time as planning for increased surges. But obviously we will have to keep that under review each week in terms of what bed availability we've got, depending on where we are with COVID. We have a whole system approach to monitoring activity, monitoring infection rates, etc. And we review our status twice a week. So that information feeds into what we'll be doing operationally. So at the moment, the idea is to try and keep our recovery phase going at the same time as making sure that we can manage any surges in COVID. But what that might mean is that at times during winter, we may be pulling back a little bit on some of our elective work, but that will be dependent on how COVID obviously continues over the next few weeks. We will always try and keep cancers and urgents going. So that's the position.
Thank you very much, Chair. Thanks for indulging.
Thanks very much. That's a good one. Rosita.
Thank you, Chairman. I suppose all of this is relative, because before I start my questions, all I can say, I don't quite understand how shielded people are more at risk of infection, because at the end of the day, if they're shielded, that is the reason that they're protected. in my area, I'm also a district councillor. I'm finding that our false campaign and our flu jab information is getting through extremely well. And there are no problems. The problems I encounter are far more from people when it comes to age concern and forget-me-not clubs, older people who are concerned that it is difficult to have face-to-face contact with the GPs. Now, my question here is, how are we encouraging, especially with the winter coming up, because if you are of a certain age, it is not actually the illness, it is the reassurance you need from that face-to-face contact, seeing your GP, and that adds to a lot of mental well-being, because if you have somebody who worries and only has a telephone appointment or can't use the IT, that is my concern. So question number one, what is being done about that? Oh, sorry, forgot to go back to the injection. It is said that over 50s are also now encouraged to take up the flu injections. So how are we going to get that message out, and how is that message getting out there, and what can we do to encourage that? My next question is very simple. An overall update on dentistry, please, because being on this board, we've got a lot of information at hand, and I can circulate those, but I have got very little information about dentistry, and I get a lot of questions. You earlier mentioned that there was aerosol training given. Now, how does that also work in relation to dentistry? And my last question, it is, and I get this also constantly, testing. The media is constantly giving a negative aspect over testing. I believe in Leicestershire it's working very well, and I understand tests are coming back within 90 hours. So can you give me an update on that, so we've got something again to reassure, because it is a lot is about reassuring and to enhance the basic messages. And thank you all very much for doing a great job. Thank you.
Just to say, Rosita, dentistry is not actually quite the remit. I mean, we've had reports on dentistry. It's actually a separate part of the NHS from the CCGs and UHL. But never mind, I'll let other.
But could we not, if so, get it? Yeah, but
yeah, sure.
Yeah.
But just to point that out. And the other point is that we've got Mike Sands talking to us in a couple of items. He's now back online again, and I'm sure he can probably give you more of an update on the way that test and tracing is going. But anyway, I'll let someone else answer Rosita's questions.
Okay. So, I think the Councillor Page's comment regarding face-to-face appointments in primary care is a really, really valid one. We've obviously at the start of the COVID pandemic, we stopped those happening. We've had to risk assess our staff to ensure that we're not putting our staff at risk from access to patients. And what we are trying to ensure is that and it's not going to be the answer that I think you want, but where it's clinically appropriate, we've got a face-to-face examination contact taking place. But our GPs, as well as our patients, are telling us that it's not that it's more than the clinical appropriate requirement face-to-face. It's that reassurance. It's that the confidence you get from sitting in front of your general practitioner to do that. So the restoration plan for primary care does look at how can we start to bring those services back online. But again, if we're into a second peak, we've got to then make sure that we're protecting our staff and protecting our patients from that. So it's a careful balance of being able to do that. And I know our practices are working with individual patients to ensure that they're trying to support the most vulnerable, the most at risk in terms of that. There is an acknowledgement that we can't rely totally on video consultation for some of our population. Some of our population love it and it's appropriate and they really like it. But it's not there for everything. So it's not a perfect answer for you, Councillor Page. It's acknowledging that we're aware of the problem, primary care is aware of the problem, they're trying to work through it, to bring those conversations back. But where it's clinically appropriate and clinically safe, they will have face-to-face. In terms of the over 50s for flu vaccination, we've got a staged approach to flu vaccination. And as I said, the first stage is for the over 65s. The second stage, starting around mid-October, will be for those people with a long-term condition. Now, that's the normal category for flu vaccination. The extended category is the over 50s, and we're awaiting confirmation from NHS England as to when that will start. And that's got to start with increased flu vaccines being made available to us. So whilst it's in our plan, we haven't got a start date for that yet. I agree with Councillor Feltham about dentistry. We're not there. And Councillor Feltham, you suggested that maybe Mike would be appropriate to do the test and trace response. I think that would probably be helpful.
Yeah, well, we've got a paper on it to down the agenda. Yeah.
Mike just said on chat he will pick it up later. But is there any way that at future boards we might be able to get a short update on dentistry?
Oh yeah, absolutely.
That would be really welcome, especially at this particular point.
Absolutely.
And I forgot to say, in my district in previous years, our falls prevention strategy has worked also extremely well. And I was involved in delivering free slippers. And we were even looking at, I forgot the names, are they called fennials, the little rubber things at the bottom of the sticks, and it did help. And we found that very, very basic measures have really got the falls down in the district. And I think it's an awful lot to also do with people at the local level and being proactive. And you know, rather than it being top down, I think that needs to be bottom up. Thank you.
Yeah, thanks very much, Rosita. And finally on this paper, Councillor Waller. Sorry, Gail. She was. Gail Waller.
Sorry, Chairman. I turned off my hand icon rather than turning my mic icon on. I apologise. First of all, I'd like to comment on the flu vaccine. Something's clearly happening because my husband told me the other day that he's made an appointment to get his flu vaccine. I haven't been asked, but then I doubt that I will, given that I've refused every year up to now from the point I was first asked. So I suspect I've been taken off the system, which actually brings me to a more serious point. I would like at some point in the future some consideration of following up with people who don't take up the offer of a flu vaccine to find out why. Yep. Because I think that could actually be useful in terms of understanding our marketing strategy. So can I put that one on the table, please? My questions, though, relating to the paper, I'd like to understand a little bit more about the sentence that is, there is investment to increase capacity in the Home First service to recruit more community nurses, therapists and social care staff. And then it goes on to talk about speedier discharge. Well, we know what Home First is, but I want to know actually how many more people have been recruited, in which categories, and what impact they've had, or is this a wish for the future? That's my first question. My second question relates to restored GP practices. We've heard a little bit about it, and we all understand the issues that COVID has caused, and should we be using online consultations, etc., etc. But I want to know if we've any target dates for having things more or less back to normal. And I suspect that there will be a new normal where a lot more people use video consultations and phone consultations through preference, let alone what the GPs themselves want. But I want to know if we've got a target date that if Mrs. Smith down the road wants to go and see the GP, she can go and see the GP regardless of clinical need, if you see what I mean. And my final question relating to that area is we're supposed to be getting optometry services restored. Well, I actually have booked an appointment for myself recently, but it's 2 and a bit months in advance. You know, I've got to wait until the middle of November before I can go and see my optician, which isn't a restored service. I mean, I'm not complaining about it, and I understand why we are where we are. But I would like to know again when we might get back to, or we expect to get back to somewhere near normal, because I am being asked these questions by residents in Rutland, and it would be quite nice to have an answer. And my final question is in relation to the NHS letter, and I suspect that I won't get an answer today, but I'll ask it anyway. In A4 of that letter, there was a reference to CCGs continuing to increase investment in mental health services in line with the mental health investment standard. And I'm wondering if that's happening locally. So those are my questions. Thank you, Chairman.
Okay, thank you. I'll take those back to front if I may. Tamsin, just give you the heads up around the coming to you with the home first one. And I think Sarah on the recovery. Just in terms of the mental health standard, we are continuing to, we had a plan to invest in mental health services to meet the mental health investment standard for this year, and we've continued to do that. Recognising the importance of mental health in this particular time. So yes, can assure you that the CCGs have continued to do that. So over to Tamsin, then I think Sarah. Thanks.
Hi, Councillor Waller. In terms of the recruitment to Home First, as you know, we had aspired to do this from 1st of April of this year, and we had to pause the recruitment for additional community nurses and therapists because we knew we were about to go into the pandemic. So the recruitment hasn't happened as fast as we would have hoped, but I'm really pleased to say that we're now back on track with that recruitment campaign, and it's a recruitment campaign that LPT has developed jointly with the 3 local authority social care teams as well. We have managed to get a little bit ahead using some of our Ageing Well monies to recruit 4.5 whole times earlier this year, and we're now seeking a further 20 nurses and therapists across the whole of LLR. We've also got money for 24 additional care staff in Leicestershire County Council, of which only 1 has been recruited to date, and that's part of the Refresh recruitment campaign to try and get hands-on care work to support people who are being seen by their Home First teams. And we've also managed to put some of the funding into the Rutland Intermediate Care team to pick up the cost of 2 posts that would otherwise not have been permanently funded there, as well as some clinical leadership for nurses in the PCN to develop ways of working together in the 3 patches in Rutland. So I hope that gives you a flavour of the recruitment.
Thank you.
Okay, so I'll cover the primary care recovery question. I think it's linked to a similar response I gave over the electives. I think it's very dependent on where we are with COVID, and particularly for primary care, it will depend on where each place is with COVID. So, you know, whether we have any local lockdown restrictions, etc. You know, certainly the level of recovery in the city has been a bit slower than in the county because we've had the additional lockdown. So there is no specific date that's set that says that things will go back to normal, because I think you're quite right, it will be a new normal, and it will going forward be a very much a mix of virtual appointments and face-to-face. But in line with what Caroline said a few minutes ago, that practices are offering face-to-face appointments when it's clinically required. So I think it will be a bit of a picture of, it will change as we go through winter, I think, in different places across the patch, if I'm absolutely honest.
Yeah, I think it's very difficult. I would have thought you answered it. I wouldn't have known where to start on that one. It's how long's a piece of string? And I think good point though about, as you say, which area you live in. I mean, clearly Leicester City and Oadby and Wigs at the moment, and now Blaby are all on the up, and we'll hear a bit more about that, I'm sure, from Mike's hands. All right, thank you very much. There's one or two things here on the chat, particularly with a couple of our members, about questions that we would have liked to have asked LPT, particularly on mental health. So if I can ask you, and if you can take note of those points, and perhaps if we can feed them through to the LPT. Is that okay, Melissa? Good. I'd like to see your thumbs up there. Right, thank you very much. We'll move on then to item 9, which is about NHS 11 first. And I'm ever so sorry to say that, for Tamsin anyway, that it's going to be you, isn't it? I mean, and I've got a voice as well, so and mine's been 5 weeks like this. It is slowly getting better, and I don't know what it is. I've probably damaged my lungs, my voice box. Anyway, thank you, Tamsin.
Well, I have to blame mine on my children, I'm afraid.
Oh,
but,
yes, of course.
But if I could ask you and perhaps to put up the presentation. So what we wanted to share with you was what we're doing in respect to developing the service of 111 to provide telephone triage assessment, self-care advice, and make sure that we signpost and guide patients to get to the right service. And prevent the number of people who are walking into emergency departments as their way of trying to access care when they need it. And it's a national initiative that is really in response to what we experienced in the first wave of COVID, where Leicestershire, Leicester and Rutland, in common with the rest of the country, saw a really dramatic drop in the number of people that were presenting in emergency departments because of anxiety about exposing themselves to the virus, but also because people were hearing the media campaigns about stay away and access care through 111. So we did see an increase in people contacting 111. We saw dramatic decluttering of the emergency departments, which really enabled them to manage effectively operationally and stay as safe places to deliver care through phase 1. So I think there's been a lot of learning about how we can use the 111 system, and a lot of transformation around telephone contact and virtual consultations that we want to build on. But I absolutely hear and recognise the point that not everybody will want to receive their care always in that way, and we need to be sensitive to that as well. So 111 First is a national initiative that helps us to strengthen all of that. So if you could, next slide please, Ewan. So LLR's been selected as the East Midlands fast follower. So we're one of the earliest parts of the country to go ahead with strengthening the pathways that we have through 111. It's been first of all piloted in Devon and London, and we've been watching with interest and very closely their experience. The first Midlands area to go live a couple of weeks ago was Hereford and Worcester. So we've just been through the process of having our plans assured by NHS England and Improvement nationally, and we were given a very challenging time frame to put this in place. So we are going to commence making some of the changes to pathways and the 111 telephone system from next week, but it's very much a soft launch, and we'll be testing that that's working well and safely before we go out more widely with a large-scale media campaign. Next slide, please. Okay, so the key principle behind the 111 First work is that we want to put clinical triage at the front of everybody's search for care or interaction with health and care services, so that we are able to make sure that we're getting patients into the right care offering at the right time, the first time. So this is one of the principles that we've kind of put in place for the restoration of services really broadly, but it's particularly relevant to when people are seeking emergency care. And we want to avoid unnecessary face-to-face clinical presentations, but absolutely making sure that when people do need to be seen face-to-face or in an emergency department, that they are done, that they have the opportunity to do that. So it's about clinical triage, whether people call 111 first or whether they walk into emergency departments or urgent treatment centres. And it's to, at the end of the day, it's fundamentally to stop people sitting in overcrowded emergency departments, potentially for multiple hours, where they're putting themselves and potentially people around them and staff at risk. So it's to keep patients, the public and our staff as safe as we possibly can. Next slide, please. Okay, so nationally, the aspirations, those were what are our local objectives and aims, but nationally, the expectation of this project is that we can reduce by 20% the number of people that are walking into emergency departments without having been either triaged first by 111, recommended to go there by their general practitioner or another healthcare professional, or brought in by the ambulance service. So this is not for severe and life-threatening patients or patients who've been told that they really need to go to the emergency department. It's for people who've decided to walk in and for whom emergency departments is possibly not the most appropriate service. So that's our aspiration. And the way that we will do that is through increasing the number of alternatives that are available and bookable through 111, and where people can leapfrog the emergency department and go straight into acute services such as the GP assessment unit at Leicester Royal Infirmary, or hot clinics that are offered within the hospital, that we do that, so we get them into the right clinic straight away. It's also introducing directly bookable slots in ED that can be accessed through NHS 111. And you may have heard some of the national media on this last Thursday. So where people do need to be seen in the emergency department, our aspiration is to book them into a time slot. That means that they can go at the right time. They don't have to go and just take a punt on how long it's going to take before they're seen. They can stay at home and go into ED when they have their time slot. And that needs to be supported by a really clear content engagement strategy and close evaluation of the outcomes and impact locally and nationally. Next slide, please. Okay. So there's three main planks, and this adds a little bit more detail to what I set out already. This is about where walk-in patients attend at the ED. They will be spoken to by a senior clinician in what we're now calling the SIV. That's not a very nice term, but you'll, if you've been to emergency department at Leicester Royal Infirmary recently, you'll have noticed that it's been dramatically reconfigured to keep COVID suspected patients and COVID negative patients separate. And there's a process by which there's a senior clinician sitting outside the ED in porter cabin who will have a talk with the patient, establish why they're there, screen them for COVID symptoms, and can route them into the COVID positive and COVID negative parts of the department. So we're building on that service then by having a conversation with them about why are you here today, what are your symptoms, and where it's apparent to that clinician that that patient isn't clearly appropriate for ED, they'll probe that a little bit further, and they can already, we book book them into alternative primary care hubs or urgent care sites across LLR. And in the first wave of COVID, actually, we relocated some of the GP resource that previously had been embedded within the Leicester Royal Infirmary Emergency Department and put that in a primary care hub site called Westcote, to do exactly this, really, to keep patients in a safe place and keep COVID negative patients out of risk in the emergency department. So we'll be strengthening and building on that, really, by enhancing the number of patients that we can route into that if they walk in. If patients call 111, 111 will go through an algorithm, but also if it looks like they are potentially going to be an emergency department referral, they will be clinically assessed and triaged by a clinician in the 111 service or in our local clinical navigation hub. And that clinician can then determine whether they need to go to ED, in which case they'll have a directly booked slot, or they will ask them to attend another service and we can book them into their own GP practice. So GP practices are all offering slots to 111 to directly book patients in, or they can book them into one of our primary care hubs or urgent treatment centres. So there's a really good offering there for patients in Leicester, Leicestershire and Rutland that avoids them having to go to emergency department for treatments that don't absolutely necessitate emergency department facilities. And as I said, for a number of patients, emergency department has been used as a way to route them into other emergency assessments and services at the Leicester Royal Infirmary, which are in what we call the emergency floor, and we can now book directly into those services without having to tell the patient to present to ED, and that minimises the risk for the individual of having multiple clinical contacts before they get to the right assessment and treatment service within the LRI. And all of those things really bring positive benefits for the public. Next slide, please. Just in terms of our project timeline, which we were given from the national team and has been a really rapid project development. As I say, we've been through assurance of our plans nationally, and we are now looking to start to implement some of those changes, including the direct booking into ED and the direct routing of patients into same-day ambulatory care service at Leicester Royal Infirmary from next Monday. We've had really good clinical engagement from right across the system, including from consultants and staff at Leicester Royal Infirmary, Derbyshire Health United and Primary Care in helping to establish this project. And we're really conscious not to go too early with a big wave of media publication about this and encouraging people to call 111. There's a number of reasons for that. Over the last few weeks, we've seen calls to 111 really spike because of the increasing rate of COVID infection, and we really don't want to put unnecessary pressure onto 111 at this point in time. We also want to check, as I said, that the changes we're making work, that they and how they're working for patients, and get feedback from patients and staff before we go out with a big communications campaign. So that will follow in October with a range of both locally delivered messages and a national campaign to encourage people to use 111. We have started some of the softer engagement with patient participation groups and the Council of Faith, and I can talk about that a little bit later on. Next slide, please, Ewan, if you would. So in terms of how we handle that communications to the public, I think it's important that we stress this is an evolution of what we have already been doing through 111 in LLR. And I think we've got a really solid platform of clinical triage and assessment within 111 to build on. We've also got quite robust IT processes already to directly book people into a number of non-emergency department services. And this is really just building on that and strengthening on that. Some of the new things about it are the concept of having a booked appointment in the emergency department, which has never been a feature of the health system in England or the UK actually, but we need to promote the benefit of that for the individual in terms of that being all about convenience for them, but also keeping them safe, just as being able to put them straight into an assessment unit is about convenience and keeping them safe. And we also want to start to kind of really promote the idea that people have a conversation with a clinician before they walk into an urgent care service. Next slide, please. I think I've said a lot of this. Just see if there's anything key there that I haven't mentioned. No, I think I've covered all of that in terms of the messages to the public. Okay, so we've started talking to key patient groups, and we had a session with the patient participation group 2 weeks ago. We had an opportunity to brief yourself, Councillor Feltham, as an early engagement. We are now preparing a range of messages for health and social care staff, whether they work for Derbyshire Health United, University Hospitals of Leicester or general practice, and those communications are all going out. We're engaging with all of our GP localities about what this will mean for their patients and what this will mean for general practice. We are developing the public-facing messages, but as I say, we're holding off promoting this until early October, and then we're also doing quite a lot of work to think about how we target those messages at different groups within our population. So the next slide talks about the equalities impact for the project, which we're really mindful of. So we have undertaken an equalities impact assessment. Thank you, Ewan, thanks. And we're currently doing some work with support from Mike's team in public health to really drill down into the data about use of 111 and what we know about how that compares to our population demographics, to identify where there are groups who aren't potentially using 111, understand the reasons why they are not, and think about some targeted messages for them. I think it's really important to stress that nowhere in any of this will people be denied access to emergency department care if they choose to walk in and choose not to take up the offer to be booked into an alternative. So that's really important, that we're not removing anything that currently exists. What we are trying to do is to guide and support people to use a more appropriate service, but they will have the choice about whether they take that offer up or not. Interpreting services have always been available through NHS 111, and all of the communications materials, both the local ones and the national ones, will be translated into the main languages. And as we learn the outcome of that work on looking at our target groups that we need to do something more with, we'll be developing more targeted communications work. Alongside all of this, we'll be seeking feedback from people about how what their experience is. We've been keeping really close to the experience in Hereford and Worcester, and the feedback from their population has been really positive about the opportunity to have a book slot into ED and how they went through clinical triage through 111. But we're really mindful our population is different, and so we want to make sure that we understand how our population are experiencing that before we go into a really significant promotion of the new pathways. Right, my voice just about held up there, so I'm going to stop there, and I can see lots and lots of hands up, so I'll answer your questions.
First one looks like, yes, Melissa March. Yeah.
Thank you, Chair, and thank you, Tamsin, for soldiering on with with your voice being so sore. My question is I guess starts with the reflection that I remember when 111 first came in, and it just being this fantastic service, and partly because you could always speak to a clinician when you first called, and you didn't have to go through somebody following a checklist on the computer who was reading what it said in front of you almost back to you. I guess I completely agree with what you're saying, Tamsin, about about this, and the idea that people have a conversation with a clinician before they're walking into ED, especially in a time of COVID, is so very important. But in order to achieve that, we must need a more considered and nuanced triage approach, especially in some of the urgent emergency situations we're assuming will be called about. Is this 111 First service going to be staffed by more clinicians on the kind of the front line of the phone? How many more, and what will the impact of that be in terms of how many more, I guess, contacts, or, you know, would everybody who called be through to that, or would they be following the tick box checklist? Because I fear if it's the latter, we're kind of building a house on the sand of the grave of the former 111, if that makes sense.
Yeah, thanks.
So we have already begun to recruit more clinicians. So it's a combination of clinicians and call handlers. There are 2 more clinicians that have already been put in post before we go live on this. We have received some national funding for this to the end of March. So we'll be now having the conversation about what's the additional case skill mix between call handlers and clinicians that we put into place. We absolutely see this as strengthening the clinical triage part of the 111 pathway. That said, I think people will be familiar how 111 works. The first thing that does happen is you talk to a call handler who will not be clinically trained, and they'll take you through the 111 algorithm. What we've already put in place locally is what we call early exit from that algorithm. So depending on what people are answering, we then try and take as many people as is appropriate into a clinical conversation. And this will be about significantly increasing the number of clinical conversations. We think about 1,200 additional patients a month will go into clinical navigation over and above what we currently do. But the selection of those individuals is basically based on whether that clinical conversation is going to add value. So if it's really clear that somebody is seriously ill, they'll be automatically put through to, there'll be a 999 ambulance dispatched automatically, for instance, because it's not in their interest to then, you know, prolong a conversation with a clinician, and they'll be picked up by EMAS. On the other hand, if it looks very much like there are some conditions that we are still going to recommend people to go to the emergency department for, and again, it doesn't make sense to prolong that conversation with them. They'll be booked in. It's really for the patients where we think there is an alternative, and what we've done through the project is go through the thousands and thousands of what's called dispositions in the algorithm with our clinical reference group to map them to who can really benefit from that clinical conversation. We want to make the best use of our clinical resource as well, so we don't want to waste either clinicians' time or patients' time by having a conversation that doesn't benefit them. And we'll have to review that to see we've got that right, but we have mapped quite a lot more of the algorithm into a clinical conversation.
Thank you, Tamsin. That's really helpful, and I hope that does exactly what it's trying to achieve here. I guess you know, the challenge is that you miss these calls, don't you? So you're told to wait, and they call you back in a certain amount of time, and I think that's great if you're in the relatively luxury position of sitting around and you're at work or at a desk or at home. I think where it gets really problematic, and I understand why any attempts to access healthcare are entirely confidential and private and from private numbers, and really support that from a vulnerable women particularly perspective. I guess from a carer's perspective, whether that's of small people or of older people or anybody, that's a really tricky situation, isn't it? Because then you can be bumped off the list entirely when you've missed your 2 calls, and that happened to me when I called 111 this week, and then had to go back through the whole process. So I guess that's the other half of my question, is about, are we concerned about some of the existing challenges within our local 111 service, which I was forwarded to London this week, and they had no record of who I was calling about. And I guess, are we concerned about some of the fractures within that? And that was my thing about building a house on the sand, really. Are we concerned about that during the winter, about this about adding to the pressures there? Probably inarticulate, sorry, thank you.
So I think it's hard to always 100% catch the caller with a call back. As you say, we do try twice. I suppose that the default in that position is that individuals are advised to go to ED if they don't get that call back. That's not what we want, but it's as a safety net. The experience that you had of being routed through to London will have been because of the national resilience arrangements for 111 when they're really struggling with call volumes, and that's less than ideal for patients. I absolutely get that. But at least we do have that safety net. And over the last 2 weeks, we've seen such an increase in calls to 111. At times, it's been, I think, 65% over our expected volumes, that those overspill routes have to work. But I do recognise that that isn't what we want for our local population, but they're there to keep people safe and to provide a service in all eventualities.
Yeah, thanks. Just to remind everybody, you don't just have to use the telephone. I used online the other day, and it was about my voice, and I got an answer. So yeah, Melissa, you're
yeah. Sorry, that's and I think you're still my question, I'm sorry, Tamsin, still doesn't feel answered. So if at this point, before we bring in this 111 first, we're already at 65% at times over capacity, how are we building a house on the sand? Are we concerned about the ability of our localised 111 to manage that if everywhere else is seeing some of the kind of localized challenges of winter and COVID and flu and falls and all the stuff we're anticipating?
Yeah, so we are obviously concerned about putting more pressure on 111 at this time. So DHU, Derbyshire Health United, have recruited a further 7 call handlers. Our concern is really the reason why we're not going to be promoting this to our local population until we know that we've got the resilience there. We need to watch really carefully what happens to the current increase in COVID infections, because that's what's led to the really dramatic rise in 111 calls we've experienced over the last 3 weeks. That said, that is starting to dip down and has dipped down over the last week. There are also national conversations now about routing the COVID 111 calls into a national COVID assessment centre, as happened at the beginning of the pandemic. If that happens, then we can really take a lot of that pressure off 111, and then we can return something a bit more like normality in the 111 service locally, which will then give us a little bit more confident that we can give that push and promote people to call 111. So that's the reason for our soft launch over the next few weeks. And what we'll be doing is testing out that the IT and the booking arrangements work. We'll be fielding the calls that we do get through those pathways, and where people are walking into Leicester Royal Infirmary Emergency Department and could be seen in the West Coast hub or in other sites, we'll be asking them to go there and booking them in if they agree to take up that offer. But we won't be saying to people, there's this fantastic new offer, please call 111, because that would create a risk, and we're not ready for that at this point in time.
Thank you.
Yeah, thanks very much. Gail Waller. Yep.
Thank you, Chairman. And again, thank you for your presentation, Tamsin. I fully appreciate what this service is trying to achieve. But as always, I've got a couple of questions around the detail of it. A number of us in the region live on the fringes, and if we were going to rush off to A&E, the last place we would go would be Leicester Royal, because it's further or more difficult to get to, etc., etc. If we ran 111, would the assumption be that we would be going to Leicester Royal if we weren't directed somewhere else? That's my first question. And related to that is, places like Devon will be obviously similarly placed, and I wondered what lessons were learned from the Devon pilot. And secondly, I welcome your reticence about advertising it more generally. I think that's extremely positive in the current climate. But when you do, how are you going to do it when you take into account the rurality of a large part of this area, and that some of the local media, print media in particular, which our older residents still like, is not Leicester based? So those are my two main questions. Thank you, Chairman.
Okay, so your question about our patients kind of, if you like, almost sort of funneled into Leicester Royal Infirmary if they call, absolutely not. So how it currently works is that all of the available services, not just in LLR, but widely come up on the directory of services, and they're ranked by clinical appropriateness and nearness to the individual. So there's absolutely no assumption that if a patient in any of Leicester, Leicestershire and Rutland calls 111 that they'll be told you've got to go to Leicester Royal Infirmary. They, as the rest of the country starts to put this project into place as well, the opportunities to directly book into other emergency departments will come on stream. As I say, we're one of the fast followers, so we'll be doing that first. But there's a schedule for go live of everywhere in the country before Christmas. So Peterborough Hospital, for instance, for Rutland residents, is their emergency department of choice, generally speaking. We'll be expecting them to start implementing directly booking slots as well, and they should be available to 111 no matter where the person's calling from. So people will end up having a choice of bookable slots. It's just at the moment that hasn't really caught up with us. So the bookable slots will just be in the places that have gone live. The lessons from Devon have been that don't expect this to be a game changer overnight, which I think is helpful. And that, but also lots of lessons about how you need to get that messaging right when you're having a conversation with people who've decided to walk in, and they've piloted things like care navigators, etc. So we're now thinking about, might we need to have some sort of strengthening of the workforce so that we aren't using the clinicians to have some of those more supportive conversations about what other services are available to them, and issues like how do we register patients who turn up at the ED without being registered. Those are issues that came out of the Devon pilot as well.
Thank you. Could I have a follow-up on that, please, Chairman? That was very helpful, Tamsin. Thank you. And I'm glad you're learning from Devon. And I hope from Hereford and Worcester as well, when some of the lessons are coming through from there. My follow-up, though, is frequently, like everybody else, I go online to look for a service or a item, good, and put in my postcode, and I'm directed to Leicester because I've got a Leicestershire postcode, LE postcode. How are the algorithms designed for your system that the person, the call handler, when they ask for your address or your postcode, knows, in my case, that Peterborough is actually nearer than Leicester?
Okay, so I'm not an expert on the algorithm design for NHS Pathways, but I have sat in the 111 call handling centre and seen what comes up on their screen. And what comes up on their screen is ranked by geographical proximity, because they can tell from the postcode that you're calling from where you're located. My experience of that is that it shows like a radius around the caller, not the health economy area that you're calling from. But I can look into exactly how that works and provide more details if you'd like.
Thank you. I would like that, please, Tamsin. Thanks very much.
Yeah, we have major problems around the edge of Leicester, clearly nearer other places like Burton or Kettering or Nottingham, etc. So yeah, useful to know about that. Rosita, you're next.
Thank you. And that, Councillor Waller, was one of my points, because I'm living in a rural area, and I must repeat and echo everything Councillor Waller just said, because most of the people in my area will be going to Rugby, Coventry and Kettering, and that is one of the major issues. And I too would welcome that to be looked at, because that would be beneficial. However, again, general point for me, in your slides, you were talking about communication objectives and activities. And for me, in order to achieve a desired objective, your objectives have got to, and your activities have got to meet the needs of what your outcomes will be. And I feel that sitting here looking at all of this, it's not simple enough. And I feel that in order to get the right message out, it needs to be far more simple. What it also needs to have communicated, I think, it is what 111 actually deals with and what to have some flow charts. So, for instance, how this fits together and how it works. And if we are talking, considering Councillor March's point, for instance, how many people know that there are only 2 callbacks? So if that is demonstrated in a very simple form, the point sinks in because it's visual. And my last point is, for instance, going back, I'm in a very rural area. I've got no media coverage. So I've got one local magazine, which is called The Flash, and everybody relies on that. There is hardly any radio coverage in my villages. There are no newspapers, and even so, I can't get all of the information out. So I think for all of these consultations, unless it is a drop to every single house, and then it probably goes in the bin, we need to look at how we can effectively communicate. Who do we approach? Do we approach the local councillors and secure their health? Do we go to parish councils? So it is rather pointless to get a message effectively out there if it doesn't go to the right people. And again, thank you for your good work. Thank you.
Okay, so thanks for those reflections about how we publicise this, and particularly that we've simplified the message and potentially use visual means. I'll definitely take that away and talk to our comms team about how they can build some of that in, and also thinking about rurality and how we get coverage of areas that don't necessarily have their own local press. That's helpful. In terms of how we're working with other areas, there's a regional programme board for this, and so I'm in quite close contact with my counterparts in the other counties in the East and West Midlands, actually, and we're sharing a lot of this information and our experiences of go live. So as I say, as more services, as more areas come on stream, those abilities to route people into other areas and directly book them will be there, but that is already something 111 will do. They are already sending people who live in our border areas to services across the border, but that will only increase, I think, as the booking comes on. But thank you for that feedback, it's really helpful. Oh, Councillor Feltham seems to have gone off.
Yeah. You've scared him off, Tamsin.
Bored him to tears, maybe.
No, I don't think so.
Maybe he needed a comfort break.
I was actually going to ask the next question. So if the Vice Chair is happy for me to ask it.
I don't know who the Vice Chair is, but why don't you go ahead, Kevin?
It's Councillor Kittery.
Painful, that.
Well, Kevin is back. Kevin is back.
Yeah, sorry, doorbell. That happens. It's one of the disadvantages of having home, isn't it? Ted.
Good stuff. Tamsin, you have done a lot of work on this, and you are thoroughly prepared, and for that you're to be praised and thanked for all your work. You're more than welcome, Tamsin. What I would ask is that, given this is a health scrutiny meeting, and when we look back at the amount of figures we had for the presentation on cancer presentations, this report could benefit from, to give it extra robustness, to have more figures and data attached to it. So, for example, it is quite full of generics. So, for example, in your introduction, the number of people attending the emergency department has reduced significantly, although more recently the number of people attending has begun to rise. And then when we look at the presentation, we have one figure, which is page 63, aim for 20% of unheralded attendances. But then when we look at the, this is what happens when, page 61, where we've got has been piloted in Devon and London, and the next bullet point, First Midlands system to go live, Hereford and Worcester. How feasible is it to receive the data from the trials in Devon and or London, Tamsin, to be able to say, this is how many people, this is how long the trial went for, this is how many people called the 111 First Initiative, this is the amount of people that were sent to ED, this is the amount of people, and concurrently, this was the amount of people that at the same time were walking through the door of the accident and emergency. This is the amount of people that were given an appointment to say go at 1 o'clock in the morning, but had to wait because at that exact point somebody came in with a presentation that required to be triaged first. And then also for the next scrutiny meeting, figures from that exact scenario, but in Leicestershire. So how feasible is it that we can bolster this excellent initiative and your great work? How can we bolster that with facts and figures so that it would almost be almost like peer reviewed? We can see the figures, we can see that it works, we can see that the trial was a success, because it's very easy, of course, for people to say in general, we've done a trial, it received excellent feedback, but until it's backed up with facts and figures, it's difficult.
So I completely appreciate that desire to see the figures. I was quite anxious to keep them out of the presentation because it was a high level summary, but as you'll appreciate, we have done quite a lot of modelling about what we anticipate the impact to be locally, although we've had to build in quite a lot of assumptions into that modelling, and we don't know whether that will be correct until we start to test it. So for instance, the unheralded patients at Leicester Royal Infirmary amount to 95 a day, and so the 20% for us is a target of 19 people who are booked away that walk in. We also have figures for how many people we think will divert when they call 111. So we have got those numbers. I'm sorry I didn't share them with you. I'm very happy to come back in a couple of months with the data on the evaluation. As you'll appreciate, that's something that the CCG is also really keen to see. One of the great things about working on 111 and clinical navigation is that actually it is really easy to capture what impact you've had, because we have so much data about the outcome of the 111 algorithm and what happens to patients. So we're more than able to bring that back to you in sort of 3 months or so when we've got data to share, if that would be helpful. Really happy to do that.
Yeah, thank you very much. And also, I mean, presumably Devon and London produced figures. Were they happy to circulate them around the country?
Actually, we haven't seen the the numerical evaluation of Devon and London, we have had the sort of qualitative feedback from those areas, and I have asked to see that data, but not yet had it shared with us. What we're now being asked to do, though, is contribute to a national, what's called a sit rep, which is a data collection exercise that will happen, and everyone will be collecting exactly the same data. And I think that will really aid the transparency of impact evaluation. So we'll be collecting that data starting next week.
Yeah, thanks very much. Yeah, it's good. I've got 3 more. Sarah Hill.
Thank you, Chair. I'm going to reiterate some points that was already made about edges, because I represent an edge, and most, a lot of people here, as you know, go to Kettering, and I think that's a valid point. And there's also potential rurality issues. I mean, don't rely on the local press here, because hardly anybody buys it anymore.
Right.
I mean, there isn't. I'm glad that sort of you're doing a soft launch with the comms, but I would suggest that you need to make the comms a very long-running thing, because there's a lot of confusion even now about where do you go when you're hurt or you're ill out of hours. It's been an ongoing issue for a long time, and I think the message to ring 111 is getting through, but it's making that, changing that over time and reinforcing it. I mean, the other issue we've got is the CCGs have for many months, and we've discussed this in the past, as you're well aware, pushed walk-in centres for when you've chopped your finger. In my case, if you remember my thumb, you walk in bleeding and they say go somewhere else. And that was after ringing 111. So my point is, I guess, for things like that, are we going to say don't walk into something that you're supposed to have an appointment for? Are we just going to get away from that and just say, please ring first? And then the other issue is my limited trips, I'm pleased to say, to A&E in Leicester, and Kettering, is there's always the drunk who wanders in. So most people are wandering off the street because they've hurt themselves and want to be fixed because they're too pissed to care. Late at night anyway. So there's sort of 3 things around that. There's the idea that we've spent a lot of effort telling people walk in, and now you're saying ring up. That's fine. It's just it's going to take a long time to get through it. And how's that poor clinician in a tent at the Royal going to, on the Saturday night, going to deal with all the pissheads who say, no, I'm not going to go somewhere else, I want to be seen now? I mean, it's a valid point, because they deal with it every weekend, I'm sure. Maybe less so recently, but it will come.
Yeah,
Thank you, Chair.
Not after 10 p.m, of course.
So thank you for that. I think that walk before you talk message is absolutely central. It will take time to sink in, but I think you're right. People are becoming more aware of 111. In terms of the poor clinician in the front of Leicester Royal Infirmary, as I said, if somebody is adamant that they're not going to go to an alternative service, that they've travelled there and that's where they want to be seen, we won't be forcing them to go away any time future. That's not part of our current plans. And equally, we're not going to ask people then to call 111, speak to another clinician if they've spoken to the clinician at the front end and they've determined that ED may not be for them. So we're going to try and make sure that people don't go through that sort of double triage and mixed messaging. But we're going to have to learn from how that goes over the first few weeks and months to make sure we've got that right. But I have sympathy for the poor person in the SIV as well. We're not going to solve all of those problems through this project alone.
Yeah, thanks very much. Sam Harvey.
Thank you, Chair. My question is just around probably the extreme age groups and very specific serious conditions that might change rapidly. So you might have very young children or very older people presenting with what might be meningitis or sepsis that change rather quickly, and you will always have people obviously that abuse systems, but equally you have those people that follow the letter of and the rules of the system completely. And my concern is that not being able to walk in, or being presented that they can't walk in, or that they may wait and delay essential treatment, and that may lead to some serious issues for individuals. And I was wondering how that message for that group of people to help would be put through. I know it's a hard conundrum.
Yes, so I think it's probably important to say, and I didn't say, so forgive me, that at the first instance we're only going to be applying this to adults. So children's ED will not at the moment be triaging people and book them away. And in our conversations with paediatricians in ED over the last few years, there's always been a real reluctance because of the kind of risks you talk about to divert children away. I think people are starting to think differently following the experience of COVID about that, and there's more openness now to thinking about how we might do that for children, but it absolutely needs to be safe. So we're still having those conversations, and at the moment we're not going to make any change to how children are managed if they walk into ED or come with their parents without having called 111 first. I have to say that some of the issues around the elderly and things like sepsis, etc., are some of the things that will trigger people into higher risk category. That means we wouldn't be asking them to present to alternative services anyway. So we're always alert to the potential for serious incidents, and I think you'll appreciate we err on the side of safety, and sometimes that's been one of the criticisms of 111, that it errs on the side of being risk averse, but that has to be there to keep people safe.
Yeah, thanks very much, Tamsin. And finally, Johnny Underwood.
Thank you. My questions actually arise from my experiences of 111. My husband became ill, or was ill and deteriorating on a Saturday evening. We telephoned 111. It took us ages to get through, and then we were told that a clinician would ring back. The clinician didn't ring back until about 11 o'clock at night. And the only way that my husband could see a clinician was to go through to Leicester Royal Infirmary for 20 past 3 on the Sunday morning. That's in the middle of the night. Now, we live right out in the sticks, no public transport at that time of night, no taxis available at that time of night, etc. So my question is, how are you going to deal with call handling, making sure that the phones are answered and you get through the call system fairly quickly? The call back from the clinicians should be timely. And finally, when we got to see a clinician at 20 past 3 in the morning, we had excellent service, but we knew that he was going to need some antivirals or antibiotics. And as we were going through to Leicester, we were trying to think of where we could get antibiotics at 20 past 3 in the morning. I actually did a search, and the only place that was open that we could find was somewhere in Nottingham, and we were on our way from Rutland to Leicester. So my question with that is, could there be a repository of the most commonly needed drugs in the local community hospitals so they could be prescribed out of hours, but without necessitating a journey through to Leicester or Peterborough or the other hospitals?
So I'm sorry if your experience wasn't as you would have hoped. I'll take that issue about availability of out-of-hours pharmacy away and have more discussions within the CCGs about it. Out-of-hours services are often located at our community hospitals, so it depends on which we had to rein in a little bit and draw back from during COVID. I don't know how recent your experience was. We're just about to reinstate a lot of the previous out-of-hours GP hours and at different community hospital locations across LLR as part of our winter plan. So that should reduce the number of people who have to go into Leicester to see a clinician in the out-of-hours period, although there will still be only 2 absolutely overnight locations. But as you know, Rutland Memorial Hospital houses one of those out-of-hours GP facilities, but it isn't 24/7 at the weekend, so it's not there in the wee small hours. I think so. We don't treat those as repositories of medicines, and depending on what part of the health service you access, you may need to go to a pharmacy to get your medications, and I appreciate that brings in some inequalities or some challenges at certain times of the the out of hours period. But I'd just say I'd take that away and we'll think about how we might respond to that better.
Sounds good. Okay, thanks very much. Thank you very much for a good discussion there about NHS 111 first. Clearly we have lessons to learn, I'm sure, and how it'll go. See what the outcomes are. So item 10 then is Mike Sands, who's been patiently sitting there after no doubt being on his Radio Leicester call. And this is basically just an update for on COVID-19, the most recent update. And Mike's the Director of Public Health for Leicestershire, but I did ask him earlier if he could at least cover some points maybe for the city and obviously Rutland. Thanks, Mike. He is there.
Luckily, I didn't do that on Radio Leicester earlier on. That would have been an embarrassing. I'm sorry, I was on mute all the way through. Anyway, so yes, so thank you, Chair. I was just saying to myself, apologies for the lack of a written brief and a PowerPoint presentation. I would say lack of time, but I'm sure as members will appreciate things are moving rather rapidly, both locally and nationally. So anything that would have written would have been well out of date by today anyway. Just going to pick off a few things, and again, I'm sure you're all kind of well aware of most of this, but just to reiterate, from a numbers point of view, clearly across Leicester and Leicestershire, we've seen a rapid rise in numbers over the last 3 weeks now since September the 1st, with rates in Leicester and Leicestershire really being sort of 4 times what they were back on September the 1st. So the figures I've got for today are for Leicester, a figure of 90.9 cases per 100,000 population in the last full 7-day spell. That's up from a low, I think, just after August bank holiday of about 25 cases per 100,000. Leicestershire is up at 36.9 cases per 100,000. And again, I haven't got the figure to my mind, but I think if we go back to the end of August, it was around about 8 or 9. Within Leicestershire, that's gone from a figure of below the national average to above, the national average now being 34.4. So again, the national average has kind of tripled, stroke quadrupled in the same time scale. The one area in LLR that bucks the trend is Rutland, which is still looking fairly pretty on a rate of 12.6 cases per 100,000. And although that's really small numbers, we're talking sort of 9 cases in the last fortnight. Even then, it's probably worthwhile remembering that that's probably sort of 50% up on where we were at the end of August. So although there is to some extent no comparison between Leicester, Leicestershire and Rutland, there is always an issue for me about, you know, even a little ripple in Rutland can look a little bit, you know, not scary, but it'd be wrong to say it hasn't gone up at all within Rutland, I guess is the main point. From a Leicestershire point of view, I won't labour the point because Leicestershire members will be aware of the figures from the briefings I've been doing, but clear blue water between the likes of Oby and Wigston, which members will have seen, is now thankfully down to 22nd in the National League table, but went as high as 2nd on Friday of last week, and Oby Wigston's rate is still 94.1 cases per 100,000 population, slightly above Leicester City's as a whole. Blaby is at 73.7 and Charnwood at 43.3. So as I said, clear blue water between those 3 districts, which are above the national average in some cases, markedly so, and the others, which although they've had increases, are still comfortably kind of around or below the national average. One bit of good news is that it does look, and pride does come before a fall, that there has been at least a stalling in that increase across Leicester and Leicestershire in the last few days since Saturday. So we've had 5 days where numbers have sort of plateaued a bit, albeit at a higher rate and not a rate that I would like to see. But for whatever reason, we are seeing maybe just a little check on that growth of numbers that we've seen over the last 3 weeks. Some of that, I'll come on to testing, might just be to do with issues with testing. But I do wonder if we are just seeing maybe that in August bank holiday, we saw an injection of people returning to work, people coming back from holiday, last bank holiday of the summer, last day of Eat Out to Help Out, all of which injected a sort of interactions into the system, which then sparked a rise in infection. And then within Leicester and Leicestershire in particular, we saw maybe a second bit as people started interacting more, not just within school, but just generally in general life outside the school gate, all of those issues. And we might just beginning to be a little bit ahead of the rest of the country and seeing that flatten out. If we could, I'd be very happy with that, because it would then avoid the worst of the Patrick Vallance, Chris Whitty predictions on Monday about those rates going up exponentially to 50,000 cases a day nationally in by October. Testing, and just picking up on Mrs. Page's question from before, good news and bad news. The slots for testing in Leicestershire and Leicester are protected. So clearly members will be aware that the testing system is under a huge amount of strain with demand outstripping supply, but there is some protecting of slots and lab capacity for Leicester and Leicestershire tests. That doesn't mean that everybody in Leicester and Leicestershire and Rutland that needs a test is getting one, but it does mean there are more slots available than maybe in Devon, to pick a low prevalence area. And we are seeing rates of testing not as high as we achieved in Leicester during the local lockdown, or indeed Noby and Wigston at the same stage, but roughly about 50% higher than the national average. More worryingly, I haven't got the exact figures, but yeah, there are delays in testing, which was Mrs. Page's question. I don't know how badly, but I think the days when the vast majority of cases were the test results were being returned in 24 hours flat are rather over. I've certainly heard stories, at least anecdotally, of people having to wait 7-8 days for their test result. And clearly, if you are, you've got symptoms and you're being asked to go into self-isolation for 10 days, if you're not getting your test result until day 8, that is a problem. So I think there are some delays in that one. My fear is that we're not necessarily seeing a full and timely picture of figures if what's happening is almost a kind of batch return of test results as they're coming back from the labs. So testing remains hugely under pressure. Hopefully, I think the Lighthouse lab in Loughborough will provide additional national capacity alongside the other Lighthouse labs, which will improve the situation. Whether that will actually mean we can go back to the days of the summer when it just felt, if you want a test, you can come and have one. Doesn't matter how ropey your symptoms. But we do need to make certain for now that we prioritise testing on the symptomatics. And I would say that, again, the positive news from me is I think that message is being heeded by people across Leicester City, Leicestershire and Rutland. I did have some figures which I've now lost, but there is a little column that we see on the testing figures around the percentage of people with symptoms who are getting, of people who get a test, the percentage who are reporting having symptoms. And it's certainly higher across Leicester City, Leicestershire and Rutland than it is for the national average. Which again, I know that would spark a debate around asymptomatics, but in the position we're in at the moment with testing capacity, that we are targeting our tests on those with symptoms does at least feel like some justifiable prioritisation which people are heeding. And then lastly, if I just touch on restrictions, because people will have seen the national announcement yesterday by the Prime Minister, we will see what difference that makes. I suppose from my point of view, and just to paraphrase what I said on the radio earlier, I was expecting there to be a national move towards restrictions on household mixing, the likes of which, of course, have been applied to Oby and Wigston and Leicester City. That hasn't happened. And again, I guess public message really and to all members is, whatever the rights and wrongs of the restrictions in place, the most important thing, I guess, is to try and get the right behaviours in the public. And so whatever the restrictions are on the rule of 6, household mixing and hospitality, the point is you just need to keep as much space as you can from people, wear a face mask if it's appropriate, and make certain you practice good hand hygiene. So just because there wasn't a ban on household mixing yesterday doesn't mean that trying to, at least in the short term, put a bit of space between you and other people just feels to me something about trying to get back to a core message instead of going, what's the rules, what can I get away with, how can I bend them? But I'm sure members would have their own view on that one, but I'll pause there. Thank you very much, Chair.
Thanks very much, Mike. My own experience of testing, Barry, by the way, I haven't told people, I'm taking part in the, I'm a volunteer taking part in the Oxford COVID vaccine trial in the 70+ cohort. And I've now I have to go up to Nottingham every month, and I get blood taken, a load of other tests, make sure I'm basically fit and well, and then I get a pack of 4 of these nasal throat type swab packs. So every Wednesday I do that. So later on after this meeting, I shall go and do the swabbing, and I'm getting results back. They were taking about 5 days. I have to say the last 2 have come back well under 3 days. Getting quicker. Still not, and I'm obviously, from the point of view of it's a volunteer trial, it's not essential. And I am, by the way, negative every time. So I've had 4 of them now and all negative. But I think it demonstrates, that there are other things going on, not just, as we all know, about the symptomatic people. I'm asymptomatic, and I'm doing it because it's part of the trial. It's part of the set thing. However, I'm coughing because I've got asthma. I don't dose myself well enough. Any questions for Mike? Gosh, Mike, I think. Oh no, Ted's got his hand up.
Marvellous. Actually, the question wasn't specifically for Mike. I was wondering if perhaps one of our partners from the Partnership Trust could answer it. For example, someone like Eleanor, do we know what are the numbers in hospital with COVID, and what are the numbers in ICU with COVID, and how many hospital deaths have we had, say, for example, in the last month from COVID?
Okay, I haven't got access to that information today. It's something I can provide.
Yeah.
Over the last couple of weeks, our numbers of patients on the gone up. I think we have seen a slight increase in ITU admissions as well for COVID-related symptoms. But I'd have to have a check on that information, Councillor Parsons, if that's okay.
Yeah.
But the evidence is there in similar ways to other hospitals at the moment, but not anything that we saw earlier in the year, without a doubt. But we are seeing that difference.
Will this be able to be sent to this committee, please?
I'd have to just double check that. They have to be validated. We do send returns into NHSI, I think, on a weekly basis, so that the data is there. But I'd obviously just need to double check that we can release that information.
Well, if it's sent to NHSI, Ewan, could you send us a link, please, to that?
You won't get it off NHSI unless it's been validated. It's not public knowledge. NHSI are, information people for NHS.
Do apologise.
Obviously,
okay, so in that case, then
once it's available,
establish whether we can have that information or
once it's available. Yeah. No, I agree. It's a good point. It's one of the key things, isn't it? Are the numbers in hospital going up? I think there's now over 1,000 in hospital across the country. Amanda.
Yes, thank you, Kevin. One thing that seems to have been slipped off the agenda nationally and locally a little bit is about antibody testing, and where we are in terms of antibodies, and clearly, the irony being, if we've got high rate of infection in Leicester City, being Wigston and now Blaby, do we have a higher tolerance level? I don't know. I suppose this is the other side of the question. I've got the numbers in front of me. Unfortunately, Rutland's not included as part of the figures that a volunteer does on a daily basis. Is we obviously have Hinckley, Bosworth, North West Leicestershire, Melton and Harborough that are green and therefore below the national average. And then we have Leicester, Oadby, Wig in measures in place, and Child and Blaby above the national average. What's happening in the green places where we're below the national average that isn't happening elsewhere in the county and the city? And have you done any sort of understanding of why these areas aren't experiencing cases as high as the other parts of the city and the county? Thank you. Sorry, bit crystal bally.
Yeah, thanks, Brenda. I mean, the first question is easy. Yeah. On antibody testing, I haven't got much to say other than you're absolutely right. It's gone really quite quiet. So I just have to pause that. I'll have to come back to you because I haven't got an update on antibody testing. why certain areas are higher than others. I'm tempted to say usual thing. If I knew I wouldn't be the jobbing DPH for Leicester and Rutland, I'd be sitting in the Department of Health and Social Care on somewhat more money than one at the moment. No, but it is an interesting one. I suppose. I mean, well, I've given it some thought, and I don't know how to put it, because I don't want to get into a Leicester lockdown debate as we had in June and July about the city infecting others. But clearly, there is something that those areas, certainly around Blaby and Oby and Wigston, the districts that have got more proximity and more of a border with the city have got a higher level. And Charnwood too, although Charnwood is probably 50-50 between Loughborough as a centre of population and the city. And I suppose more generally, one would argue that where there are centres of population, that's where rates are higher. I mean, it's just cities are. So I'm tempted to say that it is not about that Leicester City is out of control or is higher rates of infection. It was a bit of an outlier over the summer, but it isn't now. It's in the pack really for cities. But there is just something about what you could call the greater urban area of Leicester, where by definition there is just more interaction, and it doesn't matter if that is school catchment areas or travel to work areas or family connections or indeed leisure and the nighttime economy. There is just something there that looks. Also, you just need to look at it as this kind of dotted line around Leicester, which reflects those parts of Leicestershire that are closest to it. And if you do have areas which have got higher rates, then maybe they just tend to stay that way. So taking Rutland as the other example, if you've got a bit of proximity, but distance between an area like Oakham and somewhere else, you just never quite seem to get that interaction. So things stay fairly level. So I think it's probably more a microcosm of issues that we see across the country in terms of city rates, housing conditions, work conditions, and it's just played out across an area that doesn't understandably end with the administrative boundary of Leicester City, but gets into kind of whatever you want to call it, a travel to work area, a greater urban Leicester area, or something similar. The next question is, what can you do differently in those areas that you can't do somewhere else? I'm not quite certain if I've got an answer to that one, but that would be my rough understanding of why rates are higher in those districts than others.
Yes. Thanks very much, Mike. And finally on this, I've got Rosita.
Thank you. Thanks as always, Mike. A couple of very quick questions, I hope. One of the issues that was mentioned to me yesterday was by a resident who was advised not to have an antibody test because it would affect their insurance. Is that maybe a reason? Do you know anything about that? The other thing is that same resident went for a test because the child showed symptoms. And she was saying it was quite intimidating because it seemed to have appeared to be different. The last test was just driving up, somebody sticking a swab up their nose. In this case, the windows were closed. Somebody passed a lot of information on a long stick through the window. They had to read all of the information. So do you think that all of this paperwork and these the difficult having it made difficult is sort of affecting the process? And as per usual, can we have a little written briefing we can circulate? Thanks, Mike.
So thank you. Can I just check the second bit? Was that your standard antigen testing, like the Birstall Park and Ride style testing centre?
Yeah, I don't know where she went to, but she said it was extremely difficult because they had to read all of these instructions, etc., etc. And I was wondering why we've had a change from driving up, winding the windows down, sticking a butt you know, up their noses. Could you just talk me through it, just because I haven't been to one of those tests, and I just wondered whether this is making it more difficult, more complicated. Just talk me through.
Okay,
Thanks.
second one, it was probably better to pick that up offline because I'd have to have a look at the process as well.
Yeah,
my own thought is there clearly needs to be some sort of process where, you know, it's like everything, isn't it? Please read the terms and conditions. So it sounds to me like somebody is rightly going through the kind of just making people aware as to, you know, the process of informed consent, whether at the point of a test being given an arm's length instruction to read really counts as informed consent. I don't really know, but that's another matter. But there is something there just around process, which if you could email me, I'll pick up online just in case they've tightened up on what information needs to be shown to people. Regarding your first point, I'm tempted to say, it sounds like a sort of latter day version of the kind of don't go and clean the snow off your pavement because if you do, you're accepting liability. Yes. Oh, and I would need to check. I know what I want my reply to be is, what abject nonsense is that if insurers are advising you to not go for a test because it might invalidate your insurance? So again, let's pick that up offline, because if that's what's being said by insurers, it's just rubbish. Sorry.
Little bit I can give you on, although I've been having these tests because I'm a volunteer, I did actually also, when my cough started, I did actually go over to Peterborough, East of England Showground, to have a proper drive-through test job. And there were 2 lanes, and you could choose which one you went into. One was they tested you, and the other one was do-it-yourself. And the do-it-yourself one, they did indeed put a whole load of stuff through my window, and they held up a board on which it had their mobile phone number. So you had to pick up your mobile, phone her, which literally the other side of my window. She then gave me some instructions, read the pack. I then was driven off to a little side bit, and then did it all, and then did the whole thing. And then afterwards had to open my window a tiny bit to stick the sample back through, and they collect it inside. So there were literally two dry ways going through the system, and I just thought, you know, go on, I can do this. But I wish now I'd let someone else do it. But yeah, so I know that may be how that's done at Bristol, but it'd be interesting to see what the response is. Thanks, Mike. Right, I have no other questions marked. Thank you very much.
I think you've got Janet wants to come in actually.
I do.
Oh, yeah, hi. You're right in the middle. How did I not see that? Thank you very much. Yeah, Janet.
Thank you. I've got a couple of questions. My first one, Mike, is related to your comment that you were a bit surprised that household mixing has not been restricted in England. Given that it's been restricted in Scotland, what is your personal opinion on household mixing?
I've probably said this in a few things. I mean, particularly for Oby and Wigston, are the figures that are in my head. There is about half the cases in Oby and Wigston are household clusters, and it is higher than elsewhere. I haven't got the city figures with me. It's higher than other districts, but generally, you know, you were looking about a third of cases elsewhere will be household clustering. So I don't want to break a confidentiality really, but if I think about the first 2 cases that we had in Leicestershire, one was a person who inadvertently, because they didn't realise they had COVID, visited a large number of settings and triggered you know, as a first case. It's like, oh my God. But I'm not aware that waiting rooms and other settings that this person had been in, that anybody had been in contact in those circumstances, so a bit distant for a short amount of time, that they then went on to develop COVID-19. The second and subsequent cases, more returning travellers, pretty much instantly infected the rest of their household very quickly. So from the start, I've had it in my mind that the closer you are and the longer period of time you are close to somebody, then the more likely you are to get it. And that's just basic infection droplet spread. Absolutely. So by association, I know people find it hard to say, well, you mean I can get it, you know, it's my quip on a Twitter friend's sort of thing, you know, you mean I can get it in my Auntie-Pat's conservatory but not down the pub? And the answer is, well, no, you can get it anywhere. But if you're looking at a risk assessment in a COVID secure environment where people are spaced out and it's cleaned down and you're in the open air, clearly there's less of a risk than if you are in a house, windows are closed, you're close to somebody, and because you know, and they're your relatives, they're your friends, whatever, you are going to get closer to them and you just end up forgetting the core messages. So you know, there is a bit that I'm surprised at. Of course, there is a debate then about, you know, how do you enforce behaviour, when the answer is you just need to, you know, you just need people to understand that it is the right thing to do. And actually, by the time you start finding them £10,000, the answer is you've lost that particular battle. But that's another argument entirely. But if I was looking outside of restrictions, if somebody said, what's the best thing you can do to stop the spread of the virus? It's to never let your guard drop and to make certain that you practice exactly what you would do outside with people you don't know as you do with people that you do know. And I think in one of the Mercury interviews I said, you know, that basically, you know, it sounds nonsensical, but as far as the virus is concerned, your closest friends and your closest relatives are your biggest threat. And that's all you can really say.
Thank you. That's really interesting. My next question really relates to children in school. I'm talking really from the experience I have locally in Rutland, and I think probably the village school where I live has probably had guidance from either yourself or Rutland County Council. And what they've actually instigated is a staggered entry and exit for the children. But the children have to queue up on the pavement with their parents, all having a lovely little natter. There is no before or after school club, so school-age children are being sort of farmed out to either childminders or grandparents or other family members. So the virus is sort of being spread into the community from processes that keep the school safe. And I'm just wondering if that's right.
Yeah, so, you know, I think largely across Leicester City, Leicester and Rutland, you know, I would say we've not necessarily picked up that schools are unsafe and there are outbreaks in schools, but clearly what's been happening since the start of term is cases in the community are being picked up in the school setting, if you put it that way around, and that reflects that kind of increase in numbers that we've had. The behavioural thing, I think, is really interesting. I'm struggling to remember if we've done exactly the same messaging with Rutland as we've done with Leicestershire, where coming back to that kind of informal behaviours, personally, I think what head teachers have done within schools, the kind of trying to distance, and in some schools, you know, my daughter's sixth form college would be a classic case in point, you know, a mixture of in-college learning and remote learning and sort of certain timetables. The stuff that's been done around that, and then risk assessing if there is a positive case in a school, who needs to go off. So it's not just the whole school or necessarily a whole year, but trying to keep the show on the road whilst being appraised, if you like, of the risks has been great. But actually the school day doesn't end at the school gate. So there is a number of things to do with behaviours at the school gate, which again is not to blame parents. It's perfectly normal human behaviour to want to have a natter, but it's just remembering to keep your distance, to spread it out as much as you can at the school gate, and then all the way through. And that includes if you take your kids to school in a car, you know, not doing the car sharing, trying to avoid the informal play date where the kids then play in a house together after school, and then the parents have a cup of coffee in the kitchen, all the old, you know, the usual routine. It's that one, you just need to think it through every step of the journey. And it's, for me, it's more about the informal behaviours than the formal. So certainly within Leicestershire, that was what was behind encouraging parents to wear a face mask outside the school gate. Not that necessarily there was huge evidence that this was a place of transmission, but it's almost a precautionary principle. If that's the place where you're likely to forget about 2 meters, wear a face mask, because it's probably a good, you know, it won't do any harm, put it that way around. And I think where I am at the moment in terms of what we do need to do to prevent a second wave is, look, if it doesn't do any harm and it might do some benefit, that's probably a good thing to do. And because we made the mistake last time around, I think, of not moving fast enough until there was concrete evidence, and then it all gets a bit late by then. Anyway.
Can this message be got out even into sort of rural areas, such that the parental behaviour is modified a bit? And also, it just seems to me that everything has been done to keep the within school safe, but those measures are actually threatening the peripheries, i.e. the outside school safety. You've got to balance. It seems to me that there's got to be a balance between keeping schools COVID secure, but making sure that the result of that isn't increased infection being picked up outside in the community.
No, we can do that. I can pick that up with Rutland colleagues. And again, I wouldn't just pick on schools. It's the same argument we've had with the workplace where, you know, there are outbreaks in workplaces, but workplaces by and large do try and make themselves COVID secure. But the bits around the edges, the car sharing on the way to work, the night shift when public transport isn't available, you know, we know from some of the instances we've had, certainly within the city and within Leicestershire, that you know, the working adults is a parallel conversation, you know, but it's the same thing. You know, it will get you where you are not looking, essentially.
Yeah.
Thank you.
Thanks, Janet. Actually, example I've just had this week has been the issue with my local primary school. They all rush out at 3:15 or whatever it is with their parents, straight down to the play area, which is just below, run by the parish council, and pack it. And that's happened this week. So we're not talking last week, we're talking this week. So we have two options as a parish council. We could close it. That's rather a shame when it's obviously well used. And last night I happened to have a meeting with the police, and they're going to have a wander up and try and educate the parents, because that's what it basically is about, educate them. And I think, you know, the message is still not getting through, is it? But hopefully it will now start to get through, hopefully. There are ways and means. Right, thank you very much. Date of the next meeting, which is obviously the principal paper of the next meeting, is our Joint Health Oversight Scrutiny Committee response to the consultation on the reconfiguration of acute and maternity services at UHL. So important one, is for the 15th of October at 10 o'clock in the morning. So that being a due, before my doorbell rings a bell, again, I'll bid you all good day. Have a good lunch.
Thank you.
Thank you very much, Chair. Thank you very much to all the participants.
Okay, thank you.
Bye, everybody.
Thanks, Chair.